This lecture will mostly be on clearance and a little bit on elimination routes, although most of that is discussed in metabolism and in prior lectures. So the main focus will be on clearance here. So it's going to be elimination routes, plasma clearance, renal clearance, hepatic clearance, and then alternative routes of clearance just briefly. These are the learning objectives. I won't read through them this time, but I'd like you to look at them, but I'd really prefer you to focus more on what I emphasize to get, to know exactly what's going to be on the test and what I want you to commit to memory and be able to apply. I'll be emphasizing as we go on each slide throughout the lecture. So first, we'll talk about drug elimination. Drug elimination refers to the drug leaving the body permanently by one of two processes. Excretion is removal of the drug from the body. Biotransformation is metabolism of the drug. So, technically, elimination doesn't have to be excretion, right? It could be just breaking the drug down within the body. Okay, so please understand the difference between those two. And as you probably should, because, we've compared in the past secretion versus excretion, and that's movement of a drug into, or movement of a substance from one place to another place, right? So secretion means from one tissue to another tissue, whereas excretion means from inside the body to outside the body. Plasma elimination, which would be, observed by declining concentration of drug in the plasma, that does not necessarily mean the drug is being eliminated from the body. Of course, it could be undergoing distribution. So you have to be aware of what I'm referring to. If I say plasma elimination, that means specifically the drug is leaving the plasma, right? It doesn't necessarily say where it's going unless I tell you. Polar drugs are often removed by renal excretion, and that's not a guarantee, right? That a hydrophilic drug is always going to be removed by renal excretion, but it's more common. Alternative routes of drug removal include bile, sweat, saliva, and milk. Now, bile or hepatic is a big one. Of course, it's a major one, along with renal. Sweat, saliva, and milk are very minor routes. Okay, and then there's things like exhalation, but those are pretty rare, and that's the last bullet there. Of course, you could detect, alcohols on the breath through exhalation and things like that, but that's still not a major route of elimination of anything really, unless we're talking about, a drug that deposits, you've inhaled, and then it deposits in the lung, and some of it gets back out. But for the most part, again, it's a minor route of elimination of anything. Now, I actually made this presentation before most of my lectures, so you're going to see some things, some things you've already learned, and I'll try not to spend too much time on them. So first of all is the KEL, the elimination rate constant. Okay, so just remember that if something is following a first order elimination process, that will have a constant, your elimination rate or fraction per unit time. So that's going to be the KEL. And just remember, it should always look linear on an ln or a logarithmic, right, which are going to be similar. But an ln or a logarithmic plot, it should be linear for the excretion phase. KEL, again, just to refresh your memory, that's the fraction of drug removed per unit time. And the time units must be stated in order to use the KEL in calculations. So you need to understand that if you have a plot here that's in hours, you really want your KEL to be in hours to kind of make the equations work for you and give you a correct answer. It's important to know, and I just wanted to again clarify that even though the drug may not have left the body, it's considered to be eliminated from the plasma. So what I'm going to be referring to for the majority of this lecture is plasma elimination until we get to the renal part of it, and then that's very specific. But if I say just elimination, just assume I'm saying plasma elimination unless I say otherwise. Okay, and there's the linear slope on a logarithmic or ln plot. Okay, and that tells you that it's, again, first order elimination. So because we already went over the compartment models, this is going to be a lot easier. hopefully, right? So remember, if you have a linear plot, the elimination would be more of a curve, unless it's zero order. If it were zero order, it would be a line. On a ln or log linear, it would be a line, right? If it's first order. So this is very similar to what we did before. We did the KEL a little differently because we used log, but you could also use ln, and in this case it's ln C1 over C2. Remember, you could convert that to a subtraction because you're talking about the ln, so you could subtract it. So if you do the ln of C1 minus the ln of C2, and that would give you a positive number. Of course, that's going to be divided by the change in time, right? The change in time. So in this example, I looked at 6 hours and I looked at 12 hours, and the difference in time was 6 hours, so that's what I entered on the bottom there. And that gave me 0.125. And again, that's the fraction of drug eliminated per hour. And please don't ever forget, though, that the concentration is changing constantly as it declines. So we can't just, you can't just make a single calculation just by saying, how can I state this? But basically, the idea is that because the concentration is changing every second, this calculation would have to be redone and redone and redone, and that's why we end up having to integrate anyway. So you can't use this, by itself, it's not going to be as useful. Perhaps just for defining half-life, but not necessarily for defining or easily calculating the plasma concentration without, again, a more sophisticated equation. Okay, so again, I made all this before we did all the compartment modeling, but then I ended up presenting it last, so it's going to be really simple. So this is going to be familiar at the end here. The T1 half equals 0.693 over KEL. I've never really shown you how to derive that. I'm going to show you briefly here. The starting equation to measure or to calculate the plasma concentration at any given time would be, the CT equals C0, which is the concentration at 0 minutes, times e to the negative KEL times time. Okay, if we wanted to know the half-life, of course we can put in here the CT it would basically be, right, the concentration that is half of the concentration at the beginning, or half of the concentration at 0 minutes. By definition, right, that's the half-life. It's how long it takes to get to 50% lower in concentration. So we could substitute that, 1/2 CO, or 1/2 of the concentration at time 0, into the left side of this equation over here. What we get is 1/2 CO equals CO times E negative KEL T1/2. We can cancel out the COs. You take the ln of both sides, and what you end up with is, long story short, is you get this equation, and then you can manipulate it to get the half-life. Okay, again, that's only if you're interested in knowing that, how we got there. Again, you can, just, if you want to just have faith in the equation, and you could, of course, you convince yourself that it works by trying it, and then you don't necessarily need to know how we got to the end there. So a lot of this is going to be review until we get to clearance. Okay, so if you see a linear decay on a linear plot, a half-life, or KEL, does not exist and cannot be calculated. Okay, so let's look at this. 10, 20, 30, 40, 50. This is linear, right? It's going up by the same amount for an equal distance, and the bottom is linear. If you have a flat line for the elimination phase on a linear plot like this, that means there is no such thing as a half-life or a KEL, right? Because even though from 4 to maybe 8 it might be cut in half, right? 4 to 8 it may be cut in half. From, well, you can't go, well, actually, yeah, from 8 to 12. Okay, 8 to 12 is not cut in half, right? It goes from like 55 to 15. So that is not by half-lives, so there is no KEL. because it's a zero order process. So please understand that. Ethanol is a great example of a zero order elimination process. I don't know exactly how much ethanol it takes to saturate enzymes, but it seems to be almost instantaneous. Just a beer or two, I mean, it seems like maybe even less. You're already at zero order elimination. Okay, so it's pretty much almost, as soon as you start drinking, you're going to hit that zero order elimination. And again, I haven't looked at it in a while, so it might be, it might not be that little, but it's definitely something that's very easy to saturate, is the main idea there. Okay, so please understand how to recognize zero order versus first order elimination, and realize that first order elimination is much, much more common. So now we're actually going to move on to clearance. And so this is where all the really new stuff is going to really be discussed. Drug clearance is a pharmacokinetic term for describing drug elimination from the body or plasma without identifying the specific mechanism. Okay, so clearance could mean total drug removal from plasma or by a specific organ. So if we're only looking at plasma, then we're talking about plasma clearance. If I'm looking at the drug appearing in the urine, then I'm talking about renal clearance, of course. Okay, if I'm looking at it in the bile, then I'm talking about hepatic clearance. Okay. Now, the important distinction here with clearance and elimination is that, if I'm talking about plasma clearance, okay, that is actually made up of the volume of distribution, or calculated using the volume of distribution and the KEL. Okay, whereas the KEL is just your elimination rate constant. Okay, so there's a little bit of a difference there. Again, clearance is dictated by both the volume of distribution and the KEL. Okay, so we must be clear what type of clearance we're discussing. Again, like I said, plasma or a specific organ. The definition of clearance is the volume of fluid cleared of the drug per unit time. A common unit would be milliliters per minute. Okay, and a question that I had here for you to think about is, why is drug clearance not expressed in mass per unit time? How come it's not expressed as milligrams of drug, for example? Again, milligrams of drug per minute. Okay, and I'll just help you out here because that might be a little foreign to you to think of it that way, but it's actually because the milligrams per minute cleared changes constantly. The milligrams does, right? That means, if you have a lot of drug in your blood, you'll clear more milligrams per unit time. If you have a very small amount of drug in your blood, you'll clear less milligrams per unit time because it's by fraction, not by mass. So that means you can't have a constant then. There's no constant for that, so it wouldn't be something that you can put in a reference that would be consistent, right? Whereas if you have clearance, that is a constant. There's not a big difference between saying like clearance or saying percent removed from the blood per unit time, except the units are a little different, but they're still constant. So clearance is by milliliters per minute. So it's kind of strange, and we'll get into that. So what does it actually mean? Why would we calculate drug clearance by volume per minute? And how does that really make any sense? And we'll talk about that as we proceed here. And actually, this slide is kind of what I just talked about. It's exactly what I just talked about. But drug clearance is in volume per minute because, like I said, it allows us to have a constant value even as the dose or the drug concentration fluctuates. Okay, so it allows us to have a constant. And I mentioned the first bullet already, but the third one, I want you to think about that. So clearance can be confusing to a lot of people because in reality, there's no such thing as a drug that's removed completely from discrete volumes or chunks of fluid. I'm going to say chunks to make it more clear that I'm talking about like individual packets of fluid before more fluid is affected. That's not how it works, right? You don't have, like we'll just make up a volume, like 10 milliliters of blood stopping in the kidney and then getting everything removed, right? And then the fluid then continues, and then you get 10 more milliliters and then remove all the drug. and then you get 10 more milliliters, remove all the drug. Well, it doesn't work that way. It's always a fraction of the drug gets removed as the fluid is going through the kidney or going through the liver. It's always a percent, but you can still pretend that it's a volume, and that's basically what the clearance is doing. It's saying if we, let me put it this way, if you know how much drug is in the blood at a certain time, for instance, the mass of drug in the blood at a certain time, you can, and then you calculate how much mass is removed per unit time. You could say, well, since I knew the concentration and now I know the mass that was removed, I can say, well, for that mass, what volume would that have corresponded to? Right? What volume would have corresponded to that mass? Now, that's, again, it's not a real discrete volume that you're removing drug from, but it allows you to, again, use clearance as a constant. So it's almost like, it's strange, like volume of distribution, that it's not actually real. Okay, it's a strange term. So we discussed plasma clearance in the distribution lecture, and said it can be calculated by this, which is clearance of plasma equals the KEL times the volume of distribution. Now, you weren't really responsible for that at the time. Or clearance of plasma can be calculated by the elimination rate divided by the plasma concentration. One thing you might see more often, though, is calculation of plasma clearance by taking the dose, dividing it by the AUC. Okay, dose divided by AUC. Now, remember I mentioned that KEL and clearance are not identical, and that's because the KEL assumes that there's really, at that point, that's calculated when distribution has finished. So it's, you don't have to know that detail, but I want you to understand that it's not identical to clearance, because when a drug is leaving the blood in the distribution phase, now I think this will help to say it this way. The drug is leaving the blood in the distribution phase, and then it's leaving the blood in the elimination phase at a separate rate or a different rate. The clearance value takes both of those into account. So remember, the drug is leaving quickly during distribution, and then it's leaving during elimination. If you put both of those together, both of those different rates into one value, that would really be the clearance. So it means the drug is leaving the blood right after you basically get it in there, right? As soon as you get it in the blood, it starts to leave, right? So that's going to be the actual clearance. So if you boosted the volume distribution, you would boost the clearance. If you boosted the elimination rate constant, you would boost the clearance. Okay, so that's the difference between clearance and KEL. Now things are going to get a little more complicated here, and I'm not going to hold you responsible for the majority of this, especially deriving equations like this, but let's just at least dissect it or look at it a little bit, and hopefully kind of get something useful out of this. So we can break down the equation for clearance here, which is the elimination rate divided by the plasma concentration. Okay, so the elimination rate, which is on the top, is calculated by the change in drug mass. Again, we're talking about the plasma here. The change in an actual drug mass per unit time, which is again the amount of drug eliminated over time for a specific plasma concentration. This same term is equivalent to the elimination rate constant times the plasma concentration times the volume of distribution. Okay, so if we swap that in, so swap out the dE over dt, swap in the KEL, etc. What happens then is the CP would cancel out to give the other clearance equation, which is here's a clearance plasma equals dE over dt divided by plasma concentration, okay, equals KEL times CP times VD over CP. That equals the KEL times the volume of distribution. Okay. Again, you don't have to know how we got to that point. Okay, so I think the most important thing to understand is that, again, clearance is made up of the elimination rate constant and the volume distribution. So in this example, we'll use that equation, that final equation, to calculate with a hypothetical drug. And for this example, I want you to assume a patient's volume distribution is 12 liters. Their elimination rate constant is 0.125 per hour. And all you'd simply do is plug them in and get 1.5 liters per hour. So you see how the units end up? Because the volume distribution is in liters, the KEL is per hour. So that ends up working out to those units, right? 1.5 liters per hour. Okay, so hopefully that makes sense. 1.5 liters per hour is also equal to 1,500 milliliters per hour, or the typical units for clearance would be milliliters per minute in many cases, not every case, but 25 milliliters per minute. You don't know this probably yet, but I know this from just from the years of experience. But and we talked about it in physiology, but the glomerular filtration rate or glomerular clearance is about 120 to 125 milliliters per minute. So this value, 25 milliliters per minute, is nowhere near the renal clearance of something, basically like usually creatinine clearance or something like that. That's very easily filtered and eliminated. Okay, so this is not a super high clearance really. The half-life would be 5.54 if we used that equation that we have, T1 half equals 0.693 over KEL. Okay, so pretty simple calculation here. We have, like I said, the other calculation, which will give us also give us the clearance, is dose divided by area under the curve. That's from 0 to infinity. Okay, that means you can't easily calculate the AUC on your own. Okay, not accurately. You have to use a program to do that, to integrate the curve, because the curve is going to have, for every single sample, every patient, it's going to have a different shape, right? And it's not going to be easy to just integrate it by hand using the trapezoidal rule or something like that. And we'll talk about that. So generally, that has to be done with software. So I'll give you that information on this example because of that. So if we give an IV drug at 300 milligrams, and the area under the curve is 1.3 milligrams times minutes per milliliter, and remember, because it is an integration of the area under that curve, that means, think about it, that means it's like almost like a single two-dimensional object, right? That curve, you look at it as like a single surface, like a plane in a sense, and you can essentially should just multiply. So you're multiplying the units. So remember, we have on the y-axis milligrams per milliliter or concentration. On the x-axis, in some cases, we would have minutes, depending. So that's all you're doing to get that's why you're getting those units, right? You're just multiplying y-axis by x-axis, getting milligrams times minutes per milliliter. Okay. You could also say milligrams per milliliter times minutes, basically the same thing. Okay, so we have to always check though, and this is one thing I want you to get familiar with, checking that the dose of the drug is in the same units as your area under the curve. And if not, I would probably just convert the mass of the drug dose. It's probably a little easier to do that than to mess with the area under the curve units, but you could do either or. So again, in this case, both of our mass units are the same, so we can go straight to the calculation where mass cancels out. So it would be 300 divided by 1.3. Very simple. So the clearance would be 231 milliliters per minute. That's a very high clearance. Okay, that's much higher than, like I said, the renal clearance of like serum creatinine, which is our major marker of renal function. That's a pretty fast clearance. You could think of it in terms of how much plasma do you have, right? You have, I'm going to get my calculator. You guys won't see this, but I'm going to get my calculator out on my phone and do a quick calculation here that you have, right, you have about 3 liters of plasma. That's 3,000 milliliters. Divided by 231 milliliters per minute, that gives me 13 minutes, right? It's saying in 13 minutes, the majority of the blood should be cleared. Okay, that's extremely rapid, right? That's pretty rare. Okay, so also note that since AUC is determined by both VD and terminal elimination rate, the clearance of plasma is also determined by distribution and elimination. And I already mentioned that, right? Clearance is always determined by the KEL and the volume of distribution. Okay, so remember both of those factors would contribute to the clearance. So for example, if a drug had extremely slow elimination but extremely high distribution, like remember that chloroquine example, just a huge volume, like 13,000 liters, right? That would still have a really high clearance, even though it's not getting out of the body fast. If we're talking about the plasma clearance, right, it's leaving the plasma very quickly, right? So that's why it's going to have a very high clearance. So in reality, sometimes we have oral dosages, right? Sometimes we have other administration routes. So when a drug is not completely absorbed, we need to determine how much was actually was absorbed in order to calculate the plasma clearance accurately. The equation must be modified, so it's very simple. Instead of putting dose, you're putting dose times the fraction that we know is absorbed. And the only way to know that is by testing it to figure out in this experiment or in this patient population what percent of the drug is absorbed. So most drugs are, within the normal therapeutic range or dosing range, they have about the same percent absorption. And there are exceptions to that, but most drugs will have about the same percent absorption. I mean, within that given drug, right? They're all different. All the drugs are different, but within a single drug, usually doesn't change very much. So, so if we had 50% absorbed, right, and the rest of it just goes out through the feces, right, and it doesn't get absorbed, then that would be an F of 0.5, right? So you just be putting, essentially having half of your dose on the numerator, and that would be divided by the area under the curve, and it's that simple. It's actually pretty easy. So just remember, if it's an oral drug, you need to know how much of it is absorbed to even do the clearance calculation. So again, back on AUC, what exactly is it? So the area under the concentration versus time curve is a measure of the total exposure to the drug over time. That's one of the most important things to remember, that if you get the AUC and compare it from drug to drug, or dosage form to dosage form, which we talked about in the beginning, that will tell you, the total exposure of the patient's plasma, at least, to that drug. Okay, and it's a good way of doing bioavailability. If you want to measure bioavailability, or this is coming later, bioequivalence, meaning are two formulations similar enough to each other? Okay, are the two formulations similar enough to each other to consider them branded generic? Are they substitutable? We'll get into all that in a later lecture. But they use area under the curve to determine that, because it's a good measure of total drug exposure. It's determined by calculating the surface area under the curve if it were a flat object. So imagine if this were just a piece of paper in this shape, like you cut it out, what would be the total area that takes up? Okay, but instead of inches, we're using concentration times time. Okay, so it's pretty much that simple, and it's hard to do by hand, and I won't ask you to do that. That's why I said here it's not amenable to simple multiplication like a square, right? It's going to be more complicated than that. So in this case, if you look at the units, it's micrograms per milliliter times time. So this is one way to express that. Okay, that's the common way you'd put the milliliters at the end on the denominator there. If we could break this curve down into small trapezoids, we could estimate the total area manually by adding the areas of each trapezoid. I'm not going to ask you to do that, but there's the equation, right? If this is a trapezoid, right? If we broke each one of these into a trapezoid, right, and then we use this equation, we can kind of get a rough estimate of the area under the curve. So, but we'd rather use software. So this is what I'm talking about. These would be the trapezoids. Actually, that's a triangle, but you get what I'm saying, right? Trapezoid, 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 and trapezoid, and even these. It's hard to. It may not look like, but that's a trapezoid too because it's got the angle at the top. So the whole point is that that's not extremely accurate, and there's more to it than that as well. What about this? What about here, 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 here? It keeps going and going and going, right? So how do you calculate that like really long, like up to a very long time point, and get an accurate estimation? Well, the software will do that for you. They use kind of pretty common equations or well accepted equations to do that, to calculate the area under the curve from 0 minutes to infinity. Okay, and again, none of this has to be done at all by hand anymore. So one of the critical points I wanted to make is that if you're actually doing an AUC calculation, or I should say a calculation using AUC, and you're trying to determine clearance, you must ensure the dose unit is the same as the mass unit on the plot, as I think I alluded to before. So if we gave 440 milligrams of naproxen, I'm always picking naproxen because of back pain and I use it a lot. So I think it's a cool drug, and I swear I don't know why I didn't realize this until I was a professor, but its half-life is way longer than ibuprofen. So I only use naproxen because I only have to take it like once a day, and ibuprofen like 3 or 4 times a day. So that's why I picked that a lot. But 440 milligrams of naproxen is given IV, but the plot is in micrograms per milliliter in hours, with an AUC of 1259 micrograms times hour per milliliter. So we could convert milligrams to micrograms for dose and then leave the AUC units alone, as I mentioned. So you see this, right? So this is micrograms per milliliter. Okay, this is hours, but our dose was in milligrams. So how do we do this calculation? It's very simple. Convert the milligrams to micrograms. There's 1,000 micrograms in a milligram. There's 1,000 milligrams in a gram, right? It's just metric. It's all metric, so it's easy. It just goes by right thousandths, 3 decimal places. So again, dose over AUC. Just make sure the dose is in the same units as what's in the AUC. So in this case, look at that, micrograms divided by micrograms times hour per milliliter. Keep that always consistent. That's one of the most important rules of thumb that we're going to go with, especially for testing purposes. So yeah, I mean, there's a chance I'll give you grams or milligrams because that's reality, right? That can happen. And if you need to do a rough calculation, you would have to do that conversion here if you had to do it manually. So 349 milliliters per hour, or 5.82 milliliters per minute. Okay, so all I did was just basically divide by 60, right? So 349 divided by 60. So milliliters per hour, converting that to milliliters per minute. Okay, and that's very low. Okay, very low milliliters per minute. And I don't recall. Yeah, I have it at the bottom there. It's not far off from naproxen, but that's not the real naproxen clearance rate, right? I don't think it's the same. But again, it's a very slowly cleared drug, and I'm always talking about the effectiveness because it lasts so long and it actually works pretty well. So there it is. Okay, so what about, okay, what about a more complicated situation? Or let me rephrase that. What if we had clearance values for multiple organs? How can we get the plasma clearance from that, right? And the answer is pretty simple. It's just addition here. If we could measure all routes of clearance, hepatic, renal, and other, that should add up to total plasma clearance. So if the kidneys cleared 50, or we'll say like, yeah, we'll say 50 milliliters per minute, the liver cleared 50 milliliters per minute, then that would be 100. And it should all add up to the plasma clearance, right? So you can calculate one of these if you have all the others, basically. So I'm going to move on though and talk about organ clearance specifically. So organ clearance is calculated like plasma clearance, but we measure the amount of drug appearing in the urine or feces, depending, rather than the amount leaving the plasma. So let me emphasize that one more time. Whereas in the plasma, we're measuring the drug leaving. In these, for these other types of clearances or organ clearances, we're measuring the drug appearing in the excretory fluid or solid or whatever you're talking about, right? So renal clearance in this example would be mass of drug in the urine per minute divided by the plasma concentration. So think about that. So I'm saying, well, how much mass, or we'll say milligrams of drug is showing up in the urine per minute? And I say, well, whatever that mass is, if I know the plasma concentration, I could figure out what volume of plasma that corresponded to, right? What volume of plasma did that correspond to? So the renal clearance would be micrograms per minute divided by micrograms per milliliter, right? Mass of in urine per minute divided by the plasma concentration. So this is how much is in the urine per minute divided by what is the plasma concentration that we're using, that we're starting at, basically, right? So the answer is right. That's gonna be milliliters per minute, like I said. So it's important for me to emphasize this, like that. Basically, what you're calculating is how much volume of plasma is being cleared of that drug per unit time by the kidney, right? What volume of plasma is being cleared per unit time by the kidney? Okay, it's not what volume of urine is being cleared. It's how much plasma is being cleared per unit time. And that's actually hard to calculate, without having, for example, like a consistent, if we wanted to do it with this equation, right? Well, keep in mind the plasma concentration is constantly changing. Now, if we could keep the plasma concentration steady, then this equation would be very easy and be reliable, right? But in order to really, get the renal clearance for a drug that's constantly changing in concentration, we have to use some other equations that we'll talk about. Okay, so now I'm going to really dig a little deeper into renal clearance. So why do we even measure renal clearance? First of all, if we know a drug is eliminated renally, we can predict the impact of poor renal function on drug elimination, right? For example, some drugs can reach double or triple the normal plasma concentration if kidney function is impaired. So it's important to understand how much the kidney normally contributes to be able to predict how kidney impairment would affect a drug. Okay, again, if we quantify and predict the contribution of the kidney to clearance, we might be able to avoid overdosing a patient, for example. Some medications are contraindicated completely in cases of renal failure. Okay, there's many of them out there, but the rule of thumb is basically any drug that has high renal clearance, there's either a contraindication or usually a dosing reduction in the cases of renal failure or at least renal impairment. And there are many different levels of renal function that you'll learn about later on. There's impairment, there's acute kidney injury, there's chronic kidney injury, there's renal failure, and you'll learn about those later on. So again, naproxen, for our renal clearance example, if the plasma concentration of naproxen is 30 micrograms per milliliter, okay, if the rate of appearance of naproxen in the urine at this plasma concentration is 165 micrograms per minute, the renal clearance is 5.5 milliliters per minute, right? So all we're saying is, if we have 165 micrograms in 1 minute in the urine, what volume of plasma would that correspond to, right? And that would be 5.5 milliliters in that minute. 5.5 milliliters of plasma cleared of the drug. Okay. But if we actually looked at plasma clearance and not renal clearance, it would be higher than 5.5 because we'd have a combination of the renal clearance that we just calculated, distribution into other tissues, and some metabolism, right? So plasma clearance could never be lower than any of the organ clearances for a specific drug, right? Because plasma clearance is made up of all the organ clearances, right? So plasma clearance has to be the same or higher. If a drug is 100% eliminated by the kidney, then plasma clearance would be equal to renal clearance. It's important to understand, as I mentioned in the beginning, that clearance is a constant, right, as long as someone's physiology is not changing. Okay, it's independent of drug concentration unless we overdose, right? So again, all the constants are constants until something changes, like physiology, or if you go over the therapeutic range of the dose, right, if you overdose. So for naproxen, if we doubled the plasma concentration, we should double the mass of drug appearing in the urine per minute, giving the same value per clearance, for clearance, right? So that hopefully kind of clarifies why it's a constant, right? Because you double the amount in the blood, you double the amount appearing in the urine per minute, right? So it's that fraction being constant. So now I want to bring back the idea of creatinine clearance that we talked about all the way back in anatomy and physiology. So the reason why we brought that up is because it's a common measurement used to guide dosing. And I know in the clinical lectures coming up, there will be a lot more, okay, a lot more discussion of creatinine clearance and how you adjust dosing based on that. So my purpose here is to introduce you to why we use that and how that's calculated, and basically what are the fundamentals there. So creatinine clearance, like I said, it's in physiology. The calculation is the same as with medications, but instead we're using an endogenous substance instead of a drug, right? So it's the same calculation. If a patient has a creatinine clearance of 125 milliliters per minute, it means their renal function is perfect for the most part. 100 to 150 is within normal, the normal range. Now creatinine that comes from muscle. It's a breakdown product of muscle, and it's constantly, your muscle doesn't have to be getting destroyed, but it's still going to release creatinine. Okay, I'll release creatinine into the blood, and we can measure that renal clearance of creatinine, right, to determine renal function. The reason why that works is because creatinine is not eliminated by the liver, it's not eliminated by metabolism, it's eliminated only by the kidney, right? And that's why we can use creatinine to serve as a marker of renal function. Okay, if their creatinine clearance is low, it means renally eliminated drugs will likely have lower than normal clearances. So it's that simple, right? If your creatinine clearance is like 60, 50, 40, there's something wrong, right? And that means a renally eliminated drug might be very slow to be removed. It might cause toxicity. So all the renal mechanisms discussed in physiology are applicable to medications. Okay, so first of all, glomerular filtration. So you should remember, and I could certainly test you on this, remember, glomerular filtration is it saturable, first of all? That means if you reach a high enough drug concentration, will you reach a maximum, maximum rate of drug mass filtered per unit time? And the answer is no. I mean, it's almost impossible with the dosing ranges that you'd be seeing in a patient, right? So GFR or glomerular filtration is not really saturable. It doesn't really have limits, so for the most part. Okay, so remember though, it is affected by things like protein binding and things like that. But if you double the drug concentration, you double the glomerular filtration for all like normal dosing ranges. Secretion, hopefully remember what secretion is. Is that saturable? And how might renal clearance look for a secreted and a filtered drug? Right, something that undergoes both routes of removal. So first of all, that hopefully reminds you that, right, this one, glomerular and secretion, right, those are both ways of getting rid of a drug and placing it into the urine, right? So if a drug is secreted and filtered, right, and it's, for example, it's like not protein bound at all, then that will have a higher renal clearance than a drug that is only filtered and is not secreted, right? So secretion and filtration working together makes the drug clearance faster. Reabsorption is the opposite, right? It's going against drug clearance, right? It's preventing it. Okay, but secretion and reabsorption are both saturable. It's very simple in the sense, right? Those are transporters. Anything like a transporter that has to actually physically has to bind to the drug, and then the transporter literally has to move. The protein has to move and basically invert its conformation in a sense to flip the drug onto the other side of the membrane. That's a process that takes time. That means it could be saturated, right? Whereas the glomerulus is just open pores, and they're not mechanically grabbing onto something and taking time. They're just open pores, right? So it's really not saturable. Whereas again, secretion and reabsorption are saturable. So if something is highly reabsorbed, right, that will reduce its clearance because it'll go from the urine back into the blood, right? Specifically, it'll go from the ultrafiltrate, which is before the urine is completely formed, right? We're still in the nephron. Well, we're forming just the beginning of forming urine. That ultrafiltrate, if that gets reabsorbed, then we're talking about at that point lowering the clearance. So this is again the refresher on all that. So we'll start on the bottom. Afferent arteriole. Remember, there's about 1 million million nephrons in each kidney approximately. Afferent arteriole goes in. That's the blood supply. The glomerulus, the ball of capillaries. That's all it is. Blood keeps going to the afferent arteriole. Okay, so what can happen here? Of course, that's where filtration or glomerular filtration occurs, right? That is not really saturable. You double the amount of drug here, you double the amount of filtration. Everything else here, these other two things, okay, this is saturable, this is saturable. So if you have a lot of drug in the tubule, in the proximal tubule, and you keep adding more and more and more, eventually the reabsorption would be at its maximum capacity, and you couldn't really reabsorb any faster. So you'd see on a curve, it'll go reabsorption go up, 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 and then flat. Okay, secretion is the exact same. Secretion go up, 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 and then flat, except this is the opposite direction. So always remember which things are putting drug into the urine, and what is the one thing that's taking it out, and that's reabsorption. And that just means reabsorption back into the blood, of course, right? So that's it. I mean, all these together will determine the renal clearance of a drug. Okay, so you can I mean, I'll leave it at that, but you can get a lot more detailed into how actually each one of these can be measured in an experimental model individually by using needles and things like that, but we don't have to get into that now. So again, these are the answers. So GFR, or specifically glomerular filtration, because GFR is the glomerular filtration rate, but just glomerular filtration is not saturable, only works for free drug that is smaller than albumin. Okay, so not big proteins, like big protein drugs are typically not filtered, okay, because they're too large. So it only works for free drug that is less than about 65,000 grams per mole. That means if it's protein bound, whatever fraction of the drug is protein bound will not be filtered until some free drug gets filtered and then more drug gets released from the protein. Glomerular filtration could not be blocked by other drugs. There's no drug interactions at the glomerulus. That's critical to understand, and I don't know that that's intuitive to everyone or common sense. So it's something I want you to really think about. Because it is passive and the pores are so abundant, you're not really going to compete with another drug for filtration. But secretion and reabsorption are actually both susceptible to drug interactions in competition. Secretion saturable is performed by transporters. Again, it can help filtration to increase the clearance of a drug by the kidney. It can be blocked by other drugs. Reabsorption is basically the same, except the drugs are moving from the urine back into the blood. Okay, and I don't want to kind of repeat everything, but a few things I want to mention at the end were that reabsorption does not appear to play a major role in most drugs' clearance. In blocking reabsorption of endogenous substances is actually a therapeutic mechanism of some important drugs. So canagliflozin, the drug for diabetes, is a glucose transporter inhibitor. That blocks the reabsorption of glucose, as that's its pharmacological target, SGLT2, to promote glucose excretion. Okay, so we can target transporters therapeutically, or the drug itself could be a transporter substrate. Probenecid and lesinurad for gout, they both target the urate transporter that's on the apical membrane, or the membrane, in contact with the urine. So both of these transporters here are in contact with the ultrafiltrate of the urine forming, and there are drugs that can block them. Okay, so that's an example of drugs affecting, natural things, glucose and urate, whereas of course drugs can affect each other as well on the kidney transporters. So we talked about the renal clearance equation. If we look at it a different way, and if you knew plasma clearance, and somehow you knew what fraction of that clearance is due to renal clearance, well, that's a very easy calculation. Then you could actually figure out the renal clearance from that, right? It's just a fraction of the plasma clearance. So essentially, it's the same equation as the plasma clearance, except this is the fractional excretion by the kidney. So if you take, again, on the right side here is all plasma clearance. They say, well, what fraction is renal clearance of plasma clearance? And that would be that value less than 1, or usually 1, or have to be 1 or lower. Right? If it's 1, then it's 100% renal clearance. If it's less than that, then it's less than 100%, and that means some of it is not renal. Some of that plasma clearance is not renal. So fractional excretion is basically what this is talking about. So what fraction of drug excreted is by the kidney, right? So this is, again, another way to get renal clearance. That equation is for a single dose. Okay, there's another equation. If we wanted to calculate renal clearance during steady state, we must measure the area under the curve only within one dosing interval. Okay, and that's what it looks like on the bottom, well, right here, middle right here. So you would calculate the area under the curve for one single dosing interval to get the renal clearance at steady state. Otherwise, the equation is the same. And dosing interval, remember that's tau. Okay. The numerator is also all in one dosing interval. Okay, so dose, fraction absorbed, and fraction excreted renally. Okay, so that would be right the dose, one dosing interval, the fraction absorbed, and the fraction excreted renally for the dosing interval. Okay, so basically it's very similar, except it's the area under the curve during that interval, right? From the beginning of some dose in the middle of a regimen to the end, right before the next dose, right? Just that interval area under the curve. Okay, I mentioned this I think in physiology, but I wanted to mention it one more time to remind you in case you hear about it in the second part of the course. Something called inulin is also used sometimes to predict renal excretion, okay, or to calculate renal excretion. Inulin, and that that's not a typo. We're not talking about insulin. Inulin is a polysaccharide found in vegetables such as onions. Okay, it's also used as a low-calorie natural sweetener. I don't know if anyone's tried that. Trying to cut your calories. You can buy inulin on Amazon, and I've tried it. It's such a weird substance because it's a long chain, but it is a sugar. It almost honestly feels like a wax, a sweet wax if you kind of chew on it. It's a very strange substance, but it is a natural product. It's not metabolized significantly. It's not absorbed well, so it has to be injected. If you're going to study it for renal function, to measure renal function, you have to inject it. Okay, so it's given IV. If we measure the renal clearance of a drug and compare it to inulin, we'll gain more information on the mechanism of renal clearance of the drug. So I'll show you this on the next slide. So if we measured inulin clearance, and let's look at just go right to the table here. If the clearance of the drug divided by the clearance of the inulin is less than 1, that means the drug is partly reabsorbed. Okay, that means inulin clearance is greater than drug clearance. And the reason why we know this is true, that the drug is partly reabsorbed, is because inulin is not transported at all. It's not secreted. It is not reabsorbed. It is only filtered, and that's its only means of elimination, right? So it's actually slightly better than creatinine because creatinine is transported and filtered. So if we wanted to know specifically filtration, inulin's a little better for that. If the drug clearance were identical to inulin clearance, we can say the drug is only filtered because inulin is only filtered, and these look the same. If the drug clearance is greater than inulin clearance, we know that there's another mechanism getting that drug into the urine, and the only thing remaining is secretion, right? All there is filtration and secretion for getting drug into the urine. And then I have some questions here. Can you think of another reason why drug clearance may be less than inulin clearance? And you can go ahead and pause it, and I'm going to answer it right now. Okay, so the reason why drug clearance may be less than inulin clearance is if a drug is protein bound, and it's not pulled off the albumin or the protein by a transporter, or if it's highly protein bound, or even a little bit, it might still have less renal clearance than inulin. And of course, right, the drug can be hepatically cleared, things like that, but just if we're assuming it's renally cleared only, why would it be lower than inulin? And the reason would be, again, a major one is protein binding. Another one, like I says, it could be a protein drug. It's so large it doesn't get filtered. Can you think of another reason why drug clearance may be the same as inulin clearance? Is another question. And that gets at the whole, again, the transporter idea. So even if a drug is bound to albumin, right, what if only half the drug is filtered? Right, so if the inulin filtration is double the drug filtration at the glomerulus, why would we get the same amount in the urine? And the only reason that can happen is secretion, right? That's always going to be the answer. It's either secretion or filtration to get the drug in the urine, right? So if we're seeing the same exact amount of clearance by the kidney for a drug and for inulin, but we know the drug is protein bound, that's just about a guarantee that the drug is also secreted. Okay, because inulin is not protein bound, inulin is not transported. It's a very clean way of determining glomerular filtration. Okay, and actually what I just mentioned was a little different from the answer there, and those are both correct. The drug may also be reabsorbed and secreted at the same rate. Okay, so right, so does that mean, right, that if a drug is appearing in the urine at the same rate as inulin, does that mean it's not transported at all? Usually, but what if it's transported at an equal rate into and out of the glomerulus, or I should say the nephron, right, into and out of the nephron at the same rate? Then at that point, again, you wouldn't know that until you tested it using a cell model or something like that to test transport, but that can happen. So please understand all these things can happen. So be able to kind of use this kind of deductive reasoning to figure out or guess what reasons a drug might be faster, slower, or the same clearance as inulin, which is more simple. So this is the last slide, and I think you might be familiar with this all the way back from physiology. Hopefully you remember a little bit about it. So secretion, like filtration, moves drug from the blood to the tubular lumen, like we said. Secretion can be saturated and filtration cannot. Okay, we can look at this right here on an excretion versus plasma concentration curve. So again, this is the plasma concentration, and this is the mass of drug appearing in the urine per unit time. So if we double, right, from here to here, if you double the plasma concentration and then you double the amount appearing in the urine, right, and that happens over and over again, the doubling always results in double appearance in the urine, that means you're not saturating anything, right? That means anything you throw at the kidney it's handling it, right? It's you say, I'm going to double my amount in the plasma, then you're going to double your amount in the urine, and that means it's pure filtration. Okay, and it's very easy to identify as a non-saturable process. If something is only secreted, like just secreted, nothing else, it'll go as you raise the plasma concentration. Yeah, you'll get it in the urine because you're secreting it. It'll get in the urine, get in the urine, and get in the urine, but then all those transporters get saturated, right? And it doesn't care. Then if you add more and more to the plasma, the kidney says, I can't pump it any faster than what I've already been doing. So it stops. It's still pumping it, it's still excreting it, but it's no faster. No matter how much more you add, it doesn't get any faster than it was. Okay, that's pure secretion. If we get a hybrid, meaning if we have a mix of a passive or filtration process, right, which is more passive, a mix of that and secretion together, what we'll find is that we have a curve, right, that then becomes a straight line. And the reason why that's the case is because, we're doing secretion, filtration, secretion, filtration, secretion, filtration. We get to the point where the secretion is at its maximum. The only thing remaining is there's always going to be that secretion, but it's not getting any bigger. It's not getting any faster. We've saturated it. Remember, the filtration will always get bigger. And that's why we're seeing that line that's parallel with this line, basically. Okay, so now this would actually represent a different drug, so it wouldn't have to be parallel, but the main point is that it should be a straight line. Okay, a straight line after the curve, that tells us there's two components, right, to this process. right? And once you start to get linear, we know that the only thing that's going to basically be happening now is right, the saturated filtration, and then the added basically the added glomerular filtration. That's going to keep getting bigger and bigger and bigger. Okay, so all you're doing is basically, at this point, as you keep doubling, if you double the concentration, you double the filtration, and then you have that little burst, that little bonus secretion, right? That's just steady. It's not getting any better, right? And that's the reason why it looks like that. So hopefully that makes sense. I know it's a little, maybe a little new to think about, because we only really covered glucose in physiology, glucose, how it could be saturating reabsorption, whereas this is a little different because it's showing both processes, I think, together. And I think you might not have seen that in physiology, to the best of my recollection. This concludes the lecture on elimination and clearance. Thank you for listening, and have a good day.